It's really a pleasure for me to launch this discussion of the ethics. Ethics in SMA was a topic for us. We were considering it for years, but in a very kind of relaxed and philosophical level up until the expanded access program for Spinraza was announced. And literally within 24 hours, we had a list of more than 100 patients with SMA type 1 who wanted to be treated. And that prompted us to contact two of the speakers today and start a process of trying to figure out how we could provide care appropriately and ethically to this population. So without further ado, it's a pleasure for me to introduce Holly Tabor, who's an associate professor in the Department of Medicine and a bioethicist, who is also an associate director for the Clinical Ethics and Education program in the Center for Biomedical Ethics at Stanford. And she is the co-director of the ethics committees on both hospitals, and with the other speaker, Dr. Alyssa Burkhart, is co-director of the Packard Children's Hospital Ethics Committee. Dr. Burkhart is an associate professor of anesthesiology, perioperative, and pain medicine. And it's really with a great deal of gratitude and pleasure that I can introduce Alyssa to start us off on ethical considerations for SMA treatment and management. So thanks for being here.
Much for inviting us, John. And thanks to all of you for being here. I saw there's over 100 people who were interested in this topic, and it's not a huge surprise to Holly and I, in main part because the ethical issues that all of you are facing on a regular basis can be very troubling and very challenging. And so we're delighted that you've asked us to be here. Dr. Tabor and I have no disclosures today. We're going to touch on a couple of themes today. You're all living through a time of transition, as are your patients, a time from having no treatment options to having now numerous treatment options. We'll talk about briefly the impact on research. We're going to lay very heavily, spend quite a bit of time talking about patient perspectives for people who are experiencing life with SMA and the impact of cost. So in terms of this transition time, we have truly seen, since I met John, Dr. Day, when the EAP was announced for nusinersen, and it really was the launch of this time that all of you, as well as the families that you're caring for, the patients that you're caring for, are undergoing this really immense emotional weight, many practical considerations that continue to evolve, and each of these come with pretty significant ethical questions that we know that you're struggling with to various degrees. Some of the challenging decisions that we've noticed evolve over the past several years: issues around diagnosis, especially newborn screening, which has really been expanded dramatically over the past several years for SMA; disability identity and the role of ableism, so prejudice against people who have disabilities. It's not a new phenomenon, but I think that the availability of new treatments has altered that conversation. There's a real sense of information overload. I know each time you all have access to a new therapy, it creates new challenges at the bedside as well as in research. And all of our patients still have ongoing care needs that need to be met. None of the medications that are available now are curative. They're not completely making all symptoms go away, and we need to make sure that our patients still have access to the care they need. Treatment plans continue to evolve. There's a lot of concern around when, if ever, do we stop therapy and under what conditions, and how can we do that in an ethical manner? And I think we've also seen, as again these numerous treatments have come out, with nusinersen, there's many concerns around the burdens of administration, the burdens that places on the patients, as well as the burdens that it places on administrating sites. And then for the oral therapy, there's some concern around how do we make sure that our patients follow up? How do we make sure that they're getting the follow-up care that will be hopefully to help them be successful? So some of the early questions that we saw from patients in following the SMA community online as well as in person at our own organization, in terms of what is it that happens when a patient and a family are determining whether to be part of a trial or not. And we saw this in this transition period between when nusinersen was available and when Zolgensma came out. In families determining, really which trials should they consider for their children versus when did they think nusinersen would be approved. And so we've really seen families struggle with these very complicated decisions about research enrollment, experimental therapy, et cetera, especially during this very unique period of transitioning from, again, no treatment being available to, in a very brief period of time, having 2 therapies available and now 3. So some of the new research anxieties that we have heard from researchers and clinicians is, how is this going to impact future research? Because obviously as researchers, many of you want to put your time into the questions that will be most meaningful for your patients. And there are real questions around, depending on which therapies a patient has been offered or exposed to, who's going to be recruited for upcoming work and who would be included or who would be excluded. If someone has received one of the 3 therapies that's currently available, will they be eligible for future trials? And what is that going to do for the further advancement of the field in terms of coming up with potentially even more effective treatments over time? And the other thing that's really important, and I think people in the community are thinking about this right now a lot in terms of vaccination, for example. As we think about the COVID vaccine, many people are concerned around, what data is going to be collected after, for instance, these vaccines are approved. And I think for all of you, you're thinking about many of these issues as well. What is it that's going to be useful in terms of what data should we be gathering around our patients' experiences taking these medications to ensure that in this post-approval phase for these 3 medications, we're learning as much as possible to provide the safest, highest quality care for our patients. This is a paper that was published that included both Dr. Day as well as Dr. Tabor. And this was an extensive interview study that was conducted with participants and the parents, with both patients and the parents of children who were diagnosed with spinal muscular atrophy, to really understand what were their thoughts. Specifically, this was done when nusinersen was about to be approved, but before Zolgensma had come out. So there's some really interesting quotes that emerged from this work having to do with really what are the trade-offs that patients were considering. So this was a quote from an adult patient. How do I reconcile being a disability rights advocate and being in the movement and making out my life's, making out my life's work while still pursuing Spinraza? They seem inherently contradictory to me, and I don't have any answer for how to reconcile them. I was just kind of in denial about it for a while, and then I got to neurology, and as soon as they got the needle into the hole for the lumbar puncture, I started sobbing because I felt like I was betraying my community and my values, and I didn't know who I was anymore. So it can be a deeply existential question for some of our patients. This was a parent of a child with SMA. It's just not a good fit for our family and our lifestyle because our whole goal with the child is not to make her feel disabled and to have her life focused around hospitals. That would take her out of school and out of her social life. And I think it would destroy her and send her into a depression. And so this really alluded to the burdens of therapy specifically for nusinersen and how this family was struggling to see how they could make that work with the life they wanted for their child. And so when we think about perspectives on quality of life, there's multiple perspectives that are important here. And one is, what are the long-term functional improvements of treatment and what are those going to do to outweigh the potential challenges in quality of life? Again, what I think we saw that parents struggling with. And then what are the short-term challenges and impacts on treatment and whether those outweigh any potential benefits? So constantly thinking about what are the benefits of this particular therapy for this particular person. So people with types 2 and type 3 SMA had different concerns. And so there was a number of quotes that talked about feeling that the cost of the medication was putting a price on their worth as a human being, and that it gave credence to this medical model of disability, that as a disabled person, that the medical model of disability says that these are people who need to be fixed, as opposed to accepting them as they are and allowing them to have the most full life possible as a human being. And there was also a great deal of concern that in spending a great deal of money on treatment, that it was very frustrating to feel that they were then simultaneously struggling to obtain the basic functional adaptive equipment that made their life easier. So when we're talking about these issues with patients, it's important to have explicit discussions about what is valuable to the patient and making sure that they understand the natural history of their disease. And especially because for patients who have had a long period of a plateau in symptoms, it can come as a great surprise to them that they will continue to have some disease progression. We want to make sure we understand patients' goals and values, and making sure that when we're giving them information, it's actually the information that's helpful to them. So elucidating their understanding first can make that a much more productive conversation. Our families and our patients are using social media. They're using it to learn about all of these treatments. They're learning who they should get treatment from. And so it's helpful to understand how they're gathering information. And if you're talking about a research project, thinking about what is the eligibility criteria and what data do you have to support any recommendation. Certainly the issues in terms of navigating insurance, transportation for treatments that require physical presence in a healthcare setting is also something that's very important. At this time, I'm going to hand this over to Dr. Tabor to discuss cost.
Thanks, Dr. Burgart. I'm going to transition a little bit to talk about some of the ethical issues involving cost, because as most of the people in this audience will know very well, one of the key ethical challenges associated with these new therapies has been the incredibly high price tag associated with them. Historically, many expensive drugs have not been covered by insurance. It's worth thinking about the current challenges and issues around treatments for SMA in that context. And there's been a lot of work done in ethics and medical ethics specifically about how we allocate scarce resources, medication being one, therapeutics being one kind of scarce resource. And ethicists talk a lot, bioethicists talk a lot about the what was called the God Committee that started in Seattle in 1962 to allocate the scarce resource of dialysis, and the procedures and processes that were put into place to try to figure out how to decide who should get dialysis when there simply weren't enough resources available for everyone who needed dialysis to get it. Organ donation is currently another area in which we talk about allocation of scarce resources. Other drugs that are often in short, maybe not very expensive, but in short supply. We're talking a lot about allocation of scarce resources in a time of COVID, with COVID vaccines and COVID interventions. So this is the context in which some of the issues that have arisen over the last couple of years around treatment for SMA have come up. And it's important to acknowledge that we're talking about costs, both with our patients and in our institutions and in society at large. We often don't talk about some of the invisible values and invisible costs. We talk a lot about the cost of Spinraza or the cost of Zolgensma or the cost of other interventions, but we don't talk about the costs of ICU stays or the costs of Medicare and durable medical equipment. And so sometimes we're measuring certain costs and not other costs. And so it's really important to think about that and think about why we talk about costs in certain ways and how we can be a little bit more broad and transparent in the way we talk about costs and the way that our patients and families may think about cost. But that said, with that historical background, it's important to know that in this case, Spinraza, but also other drugs as well, are sort of in a different stratosphere in some ways than many other kinds of drugs. And these are just two examples of some of the media that came out around the time that the drugs were being tested and Spinraza in particular was being tested and going through approval, and some of the challenges people had in getting insurance companies to pay for it in the beginning of that time period. So I think again, SMA is not the only clinical condition in which this is an issue. A lot of CAR T treatments for cancer are also sort of astronomically expensive. IVIG can sometimes also be very expensive. So I think this is a broader debate that's happening in society as well. Next slide, please. So I want to talk a little bit about what happened at the time that Zolgensma was in the process of being reviewed for approval, and there were discussions happening about the relative costs and whether or not insurance should cover Spinraza versus Zolgensma. And this was reviewed by the ICER, which is an organization that does review of different things like drugs and look at cost effectiveness. And there's a lot more we could talk about that during the panel discussion. But I wanted to cite a couple of things from their work. David Rind, who was the chief medical officer, noted that both of these drugs appear to dramatically improve the lives of children with SMA and their families. And while Spinraza at that time had a broader body of evidence and provided more certainty around the health benefits because of that evidence, the limited data that existed at that time on Zolgensma suggested that gene therapy has the potential to deliver large benefits through a one-time treatment rather than through a lifelong treatment. And what was important about what ICER came up with at this time was they really argued that the one-time treatment with Zolgensma was more cost-effective than Spinraza. And that was what they said in this report from ICER. And they were essentially trying to make an argument that Novartis has an opportunity to demonstrate both scientific and ethical leadership by setting the launch price of Zolgensma in line with the benefits patients will likely receive. And some people think that this argument that ICER put out in February 2019 actually did influence the pricing of Zolgensma when it was initially rolled out. Next slide, please. And I want to point out, without going into too much detail, that even prior to the existence of expensive gene-targeted and gene therapies for things like SMA, there have been different discussions and modeling, particularly among healthcare economists, about how to think about value-based pricing for drugs. And this is a table from a really nice viewpoint in JAMA in 2018. And you'll see on the far left column, there are different concepts: value-based pricing, outcomes-based contracts. Mortgage pricing is a really interesting idea, where you think of the cost of a drug like a mortgage that's being paid for over time. And then you'll see in these different columns the definition, whether or not you need existing evidence of benefit, whether it aligns with price with benefit at market entry, and some examples. So these are the ways different insurers and funders, companies that make, study and make these drugs, and to a less degree, unfortunately, clinicians and families have talked about some of the different trade-offs that come in thinking about how and whether to pay for these very expensive drugs. I think there's a separate question of whether or not the drugs are rightfully priced at whether or not the high prices are actually justified. But I think in some cases for the gene therapies, there is a lot of data to suggest that there are good reasons why the drugs are priced very high. I mentioned again, the costs are not just limited to the drug costs. There's invisible, anticipated, and unanticipated costs. I think, the costs of administration, the hospital costs, the travel, particularly with Spinraza, that people have to be able to take time off from work and travel to a place where they can get the administration of the treatment, the costs of ongoing regular care, both the costs in general for people with SMA, but also the costs that may be costs that wouldn't have happened if they were patients with SMA1 who unfortunately were likely to die sooner if they didn't have one of these drugs. Those are costs, not just the cost of regular care, but the cost of other kinds of things that may come up because we've successfully extended their lives. And the long-term comorbidities, maybe we'll talk about this in the example, but there are some, different aspects of SMA that we may start seeing in patients that we would not have seen, particularly SMA1 patients, beyond what would have been their expected lifespan. And side effects. I will say that in our 2 studies we've done interviewing people about decisions about whether or not to take Spinraza, many people, especially SMA types 2 and 3, really talk about concern about side effects, and particularly how it's going to potentially inhibit what they come to find to be important parts of their quality of life, like being able to go to work. So that's really important. I want to show you a couple of quotes from these studies about factors that influence treatment costs, because I think to some degree, I will admit that, there were certainly large numbers of people who wanted these drugs no matter what, under any circumstances, but we were somewhat surprised to see some ambivalence. And these quotes sort of demonstrate that. A parent of an SMA type 2 child said, "What happens if the child doesn't get the drug? How far back are we going to regress if she starts it and then doesn't get it? What happens if no insurance is ever guaranteed and we can't pay for it?" The emotional roller coaster of knowing she could get stronger and then not knowing what would happen terrified us. So, I mean, I think that's a challenge, particularly with the drugs that will require more than one administration, like Spinraza. This adult with SMA type 3 said, "I worry down the line, and if I say, 'Hey, insurance company, will you pay for my new wheelchair?' And the insurance company says, 'Well, why aren't you getting Spinraza?' And I say, 'Well, because I don't want to get Spinraza.' And they're like, 'Well, we're not going to pay for your new wheelchair because theoretically you wouldn't be in a wheelchair if you took Spinraza.'" And I think that reflects, again, the real challenges that adults with SMA types 2 and 3, and with a lot of other conditions that have similar features, struggle to get things like wheelchairs replaced and paid for, and they recognize that make it harder. Our participants also talked about other factors influencing their decisions about treatment. The time it takes to get approval from their insurance company, the time it takes to get regular injections and manage side effects, and the need for lifelong commitment for some of these interventions. And a lot of them talked about the travel transportation. I will say that it was really striking to us that a lot of adults with SMA types 2 and 3 do not regularly see neurologists who necessarily have a lot of experience with SMA. And so, and they don't live near facilities. We had many people who don't live near places where they could get SMA, so they would have to travel to an administration site. And this person described not having the money for the travel, but also needing someone to be a personal care assistant to travel with them, and not having the financial resources to do that either. Next slide, please. This was one of the findings that was really most striking to us, was, again, more among the SMA types 2 and 3. But this was an individual with type 2 who said, and I'm going to read this quote in its entirety: "I'm 40 years old, right? Based on my progression, what I can see, I've given myself 20 good years. If I took that 20 years and I put that towards Spinraza, then it would amount to about, I think, close to $8 million, right? If I had $8 million handed to me and someone said, you could either take Spinraza and you might be able to open the hell out of this Ziploc container, or you can take this $8 million and get all the intended care you need to never have to fight to get a new wheelchair. You can swim in a pool. You can have an accessible home. You can go anywhere you want to go. You never have to worry about your van breaking down. Everything that I could ever need would help me stay healthy and independent. I could buy with this $8 million, right? Over being able to open a Ziploc container really well. I would be more cured if I put $8 million toward that than to this drug." And I think for us, this was really quite moving in some ways, but reveals some of the fundamental health inequities that exist for people with disabilities like SMA in our society, but also the challenge in that even if insurance would pay for that, that may or may not be the choice that people would like to have for those resources, but they don't have that choice regardless. It's not, this person fully acknowledges that it's not that she's being offered $8 million to either get Spinraza or to have these other things. And so this was a very striking quote about that. Next slide, please. Another participant said the priority around Spinraza was very medically driven. The cost, it really hurts me, it hurts people, and it hurts our world. It's putting a value on the idea of a cure that really isn't there. An overall idea of disability being so atrocious that being, this is the same woman, that being able to open a Ziploc container is more important than having a full life that you can engage with. So seeing sort of some inherent medicalization of disability, the medical model of disability inherent in that. So obviously we only have time today in our talk component of this session to talk about some of these issues and introduce some of these ideas, but we really need to work collaboratively with healthcare economists, drug companies, and policymakers to develop innovative approaches to price and assess the value of gene therapies, especially for rare conditions. Access and equity are really key. We can't make gene therapy something that's only available to the very wealthy or the highly insured. And we also can't only be focused on funding the therapies and not the other things that people need to live the fullest and healthiest life possible with SMA. Gene therapies for rare and disabling conditions like SMA will challenge long-held assumptions about cost-effectiveness calculations and values. A lot of those calculations may tend to be biased against people with rare diseases, and we need to acknowledge that and find other ways to still provide therapies and payment for therapies for people who need them, especially when they're life-saving in the case of SMA1. Patient stakeholder engagement is really going to be key to success. I didn't go into this, but we have another paper that came out earlier this year in Genetics and Medicine about how patients and families used social media to talk about Spinraza and gene therapy when they started to be approved. And that is where most people got their information, really, really quite striking. And I think it also reflects the fact that many people feel, unfortunately, somewhat isolated from other sources of information. So we need to be aware of that and talk with patients and stakeholders throughout the process as clinicians, but also engage them in the policy making. And I think if industry, back up one second. If industry doesn't come up with practical and pragmatic solutions to cost for these therapies, the government likely will. And this makes industry very, very nervous. And it's worth noting that this is what is already happening in Europe. I think that's a good thing in that it puts some pressure on stakeholders to come up with other solutions, but it's simply not sustainable under the current models. So we have to figure out different ways to deal with it. Next slide, please. So our major themes in SMA right now, I think, as Dr. Burgheit mentioned earlier, are that we're in a time of transition. There's still a lot of research going on, even about the drugs and therapies that have already been approved. That patient perspectives, both in individual clinical encounters and more broadly in policymaking and ethical framing of these issues is really important. And that we really need to think creatively about the impact of the cost and how we think about that. And I want to say thank you very much to Dr. Day and the organizers, and to all of you for being here today and for being interested in these topics. We did want to recommend two books that we really have influenced. Actually, there are more than two, but these two books that have really influenced the way we think about some of these issues. The person on the right is Alice Wong, who's an individual with SMA, and she has an amazing book that came out this year called Disability Visibility, which I highly recommend. And Ben Matlin, who also has SMA, has written a really powerful book called In Sickness and Health, Love, Disability, and a Quest to Understand the Perils and Pleasures of Interabled Romance. And there are several individuals with SMA profiled in that book as well. So Dr. Berger, I'll hand it back to you.